whole complex disease differently. The phenotypes vary, and this is again important because PCOS in a Caucasian woman looks very different from PCOS in a Mediterranean or a South Asian woman or a PCOS in a Chinese woman. So we are a hairy race. When we use the modified Ferriman-Galway score, the number of cutoff for our population is a score of 9. 9 to 10, more than that is hirsutism, whereas it is 2 for the Chinese race. So it varies, and the other problem with us is, and that number in one study from UK where 52% of the young girls who were South Asian had polycystic ovaries in that study. Really scary statistics. And then we have early age of onset, greater insulin resistance, and more severe symptoms. So our PCOS is much more severe than some of the other countries. So I'm just going to skim through the diagnosis of PCOS very quickly. There are many diagnostic criteria, but just concentrate on this one here, the Rotterdam criteria, which uses 3 points, which is oligoanovulation, hyperandrogenism or androgenemia, and polycystic ovaries. In the NIH, there is no mention of polycystic ovaries, although it's called polycystic ovary syndrome. But you know, if you have to have 2 out of 3, it means there are possibilities. So what are those possibilities? There are 4 phenotypes that are possible, A, B, C, and D, if you use the Rotterdam criteria. And this Rotterdam criteria is now also accepted by ESHRE as well as the American Society for Reproductive Medicine, as well as Monash University, which is making quite a lot of headway in PCOS. And the other interesting thing to note is that if you look at the bottom part at the cardiovascular risk, you have the phenotype A where all these 3 factors are present. You have the phenotype B where you have hyperandrogenism and oligoanovulation with no polycystic ovaries. These 2 phenotypes have the maximum cardiovascular risk factors. So obviously these patients are different from the other PCOS. The phenotype C, where you don't have ovulatory dysfunction, you have the other 2, they have less cardiovascular risk factors, less severe, and the D are best off. And there is also an argument this D is not really polycystic ovary syndrome because they don't have hyperandrogenism. So another thing about the ultrasound, and this is the bane of our existence, I'm sure it's for you as well, all these ultrasounds that keep getting repeated and cysts getting counted, and they're all transabdominal, and patients think that these cysts are going to disappear and they were 6 before and 12 now and this kind of a thing. It just doesn't work. If it's a transabdominal ultrasound, you should look at the ovarian volume. If it's a transvaginal and the new probes of 8 megahertz, 20 is the cutoff, that many follicles, not cysts. These are not cysts, by the way. You know that, I'm sure. So a 10 greater than 10 ml volume, and with irregular menstrual cycles and hyperandrogenism, when you have these 2 things, you don't have to do an ultrasound unless you think that there might be an ovarian tumor. And also 20% of the women will have polycystic ovarian morphology, but they don't have polycystic ovary syndrome. So be very beware of this category, because you will be unnecessarily labeling them as polycystic ovary syndrome with all its connotations. So before I go on to management, let's quickly look at the manifestations. And the other thing I want to say is that the management of PCOS is patient-driven. You have to ask the patient, what is it that you want treatment for? So a young girl might want it for her hair. A married girl wants both treatment for her hair and infertility. So she can't have both at the same time. She has to decide whether fertility first or hair treatment first. And with regards to the hair, it is also a patient-driven decision. You can't say to a patient, oh, you have very little hair, this is fine. If it's not fine for her, you better treat it. So all the features of obesity is very important to deal with, and oligoanovulation and pregnancy losses, subfertility, raised hyperandrogenism. And all those other features in the other box are metabolic consequences. That is something that you need the help of a physician for. You must refer them for care of those conditions. and it is very important that these conditions are treated simultaneously. So the first thing you need to exclude when you see a patient, particularly if it's a married person in this country, then you have to exclude pregnancy with a beta HCG and do a progesterone challenge test. If there is withdrawal or no withdrawal bleeding, then look for some other cause of this amenorrhea, not PCOS. So there should be withdrawal bleeding. And after that, you go into the business of excluding other causes. So hyperprolactinemia, hypothyroidism, and late onset congenital adrenal hyperplasia, 21-hydroxylase deficiency being the most common. So you measure the 17-hydroxyprogesterone. After you've done that, you establish your hyperandrogenemia by doing a total testosterone. So total testosterone from the lab point of view is more reliable than free testosterone, and you can do that. I mean, you have markedly elevated, and you can have normal total testosterone as well. So, you know, there are other things to look at. You need to look at the sex hormone binding globulin and calculate the free androgen index to see how much of this testosterone is biologically active. And when you have very high levels of testosterone, then that means that you have to look for an ovarian tumor. And clinical indicators of an ovarian tumor is when you have onset of hirsutism, which is later than puberty, and it is very intense and very rapidly progressive. So after you've established hyperandrogenemia, you may want to do a DHEA sulfate, because something like 50 to 60% of PCOS patients may have raised DHEA sulfate, but when you have very high levels, more than 7,000, then you need to think adrenal tumor. So androstenedione is something that we don't do normally. But if you have a hirsute patient and normal testosterone and you're looking for why, you may want to do this, because isolated androstenedione excess, which is a weaker androgen in the steps of synthesis, is also seen in PCOS, and 2 studies have been reported, one reporting 4.1% prevalence and the other reporting 23% prevalence. AMH is in evolution as a diagnostic marker, surrogate marker, because it is secreted by the granulosa cells of the follicles, and the more follicles you have, the higher the AMH is going to be. But the diagnostic criteria have not been settled yet. And you have to screen for the metabolic abnormalities with the various things. So I've talked about the priorities of management lie with the patient. The decision lies with the patient. So when you're managing, you have to manage the reproductive part, the hyperandrogenism, the metabolic and the psychological features. And it's very important, this is a lifelong condition, much like diabetes. Many of these women will go on to develop diabetes. So education of the patients, empowerment, multidisciplinary care and lifestyle intervention is very important to manage the weight, which is an integral part for most of these patients. And depression and anxiety should be sought, should be addressed, so that the patient's emotional well-being is addressed. So let's look at, if, for instance, hirsutism is what needs to be managed. I'm largely relying on the most recent consensus guideline to which most societies are subscribing for treatment of PCOS, which is the Endocrine Society Update 2018. Screen all women if you suspect PCOS with total testosterone, and if there's mild hirsutism, then you need to go for oral contraceptive pills, which will suppress the ovary, chaotic hormone production, will increase the SHBG, so biologically active testosterone will go down. And then you may, after 6 months of this, if the treatment results are not satisfactory, you may want to add an anti-androgen. But if the patient's hirsutism is moderate to severe, you may start with both at the same time. So this is a class that we try to stay away from, flutamide and bakelutamide. These are used for prostatic cancer. This is again an androgen receptor blocker. We don't use it much for, not recommended for this. And you do not use metformin for hirsutism. You use it for all sorts of other reasons, but not for hirsutism. So the other thing, you with OCPs, you are suppressing the ovary, and you should be using OCPs that have less androgenic progestogens. Now this is a dilemma because the older generation of progestogens are more androgenic, and those are the ones that we have here. So we have to try and use the less androgenic ones. And but in practice it doesn't really matter. Think about the thromboembolism. Drospirenone is an androgen receptor antagonist add a pill. There is a problem with this, and that is of the this. So Famila has levonorgestrel, by the way. That's the difference in ventricular thromboembolism between the two compounds.